So turning now to the Cancer Center Grand Rounds, we actually are fortunate to have two outstanding faculty sharing with us our work. You know, an important mission is advancing Yale science into the clinic, and I think both of our speakers can address that. So our first speaker is Dr. Joseph Kim, who, as you know, is an assistant professor of medicine and one of our leaders in genitourinary oncology, who's going to give us an update on the science and therapeutics in GU oncology.
Thank you, Charlie. It's what an honor to give our first grand round for year 2017. I wish everyone Happy New Year's. So I'm going to dive into this talk titled Emerging Therapies in GU Cancers. Here I'm going to focus primarily on bladder cancers and prostate cancers and some of the IITs that I've been working on for the last year or so. So this is my disclosure. Again, this is the outline of my talk. I'm going to talk briefly about the evolution of systemic therapy in urothelial carcinoma. Can you hear me okay? Yep. All right, this is outline of my talk. I'm going to speak briefly about the evolution of systemic therapies in urothelial carcinoma and to give you leading up to the recent approval of atezolizumab in urothelial carcinoma. And also want to give you a clinical updates on PD-1 and PD-1 inhibitors in metastatic urothelial carcinomas. And I'm going to talk about two of my IITs, one with the mTOR inhibitor in TSC-mutated metastatic urothelial carcinoma, and the second one involving PARP inhibitor and the VEGF receptor TKI for metastatic prostate cancer. So to talk about the urothelial carcinoma is the tumor that arises in the urinary tract, all the way from the renal pelvis, ureter, bladder, and the proximal one-third of the urethra. The management of urothelial carcinoma really depends on the staging of this. For superficial disease, for stage 0 or stage 1, it's primarily managed by TURBT, followed by the intravascular therapy. And for the tumors that invade the muscle layer, is treated with a neoadjuvant chemotherapy followed by radical cystectomy or nephroidectomy. And the tumors that spread beyond the lymph nodes or distant organs is an incurable disease and treated with cisplatin-based combination chemotherapy. To understand the evolution of systemic therapy, I'd like to review the history of this. Cisplatin was the first chemotherapy approved in 1978. This was really developed by our grandfather of chemotherapy in bladder cancer, that is Alan Yagoda, who worked at Memorial Sloan Kettering at the time. And over the following decade, he and his colleagues developed a combination chemotherapy called MVAC, consists of methotrexate, vinblastine, adriamycin, and cisplatin. And for the following 2 decades, the advance has been merely with the different variations of combination, cisplatin-based combination chemotherapy, either with the GEM-CIS or docet. Demonstrating survival advantage by over about 2 months compared with the best supportive care. But that data did not fly here in the US, thus it was not approved here in the US. And really recently, last May, atezolizumab, which is the anti-PD-1 PD-L1 antibody, was approved in second-line setting for metastatic bladder cancer. So atezolizumab, this data has been presented multiple times in many different meetings. Atezolizumab is a humanized anti-PD-L1 antibody that inhibits the binding of PD-L1 to PD-1 and B7-1. The binding, the inhibition of this pathway restores the anti-tumor T cell activity and enhances the T cell priming process. And this interaction leaves the PD-L1 with the PD-L2 and PD-1 interaction intact, and thus potentially preserving the peripheral immune homeostasis. And as we know, PD-L1 is expressed in many tumor types, including bladder cancers. And really, depending on what assay you use and depending on the cutoff, the PD-L1 expression can be seen up to about 70% of bladder cancers. And we talk about PD-L1 expression in immune cells, not so much in tumor cells in bladder cancer, because PD-L1 expression in immune cells is correlated with the response, but not its expression in the tumor cells have been associated with the response to a therapy. This is a waterfall plot of our phase 1 trial. This is the first about 78 patients in the study patient population. A little over half of the patient had a regression of the tumor burden. And as you can see, the biomarker status does not really pan out to be the exact predictive biomarker, although the higher response was seen in patients with IC score 2 or 3, but nonetheless, there were IC 0s and IC 1s who still derive benefit to this class of therapy. Again, the response rate in the IC2 and IC3 were up to 50%, and the IC0 and IC1, the response rate is about 17%, which is actually not bad given the historical data of second-line chemotherapy is in the orders of about 10% range. This is an example of one of our patients who was treated downstairs in the Park Street building. This is a patient whose tumor actually tested negative for PD-1 expression, but nonetheless, this patient actually had a quite good response of this abdominal lymph node. Really, based on this set of data, US FDA actually granted a breakthrough therapy designation in May of 2014, and soon thereafter, there were a couple of clinical trials were developed. One is the IMvigor210 study. This was a phase 2 study designed to definitively assess the anti-tumor activity of atezolizumab in second-line setting for metastatic urothelial carcinoma. Actually, this study also had a cohort for first-line cisplatin-ineligible patients as well. And there was another phase 3 trial was developed comparing chemotherapy versus the atezolizumab as well. So in this IMvigor210 study, this study had two co-primary endpoints, really looking at the response rate, one assessed by the central review and the second really assessed by the investigator. And the secondary endpoints include duration response, PFS, overall survival, and also there's some biomarker studies as well. The primary endpoint, the response rate in all patients were about 16%, and in marker positive patients, and IC2 or 3 was about 28%. In the marker negative, IC1 or IC0, the response rate was about 20%. This is a survival data of this IMvigor210 study. The median overall survival was about 7.9 months, and the 12-month survival rate was about 37%. And given the possibility of pseudoprogression, many of our patients were treated beyond the radiographic progression, and the investigators also report the clinical outcomes of these patients as well. And as you can see, these patients, about 20% of the patients ended up having a response after radiographic progression by the first scan. And about 30% of the patients had disease stabilization, and more importantly, the survival data is also quite promising. The median overall survival in these patients were 11.4 months. So in summary, really based on this data, US FDA approved atezolizumab as the first anti-PD-1 antibody, PD-L1 antibody in treatment of advanced or metastatic urothelial carcinoma, irrespective of PD-L1 expression. And this approval was really based on clinically meaningful and durable responses that were noted in these heavily pretreated patients. And the survival data and the safety profile also compare favorably with the historical data. And there's ongoing phase 3 trial comparing atezolizumab with the chemotherapy that is still ongoing at the moment. And I'm going to switch my gear to talk about the different PD-1 antibody that's pembrolizumab. This was actually presented at CC meeting last November. So pembrolizumab is a PD-1 antibody. Again, the first phase 1 data was presented at the annual meeting ASCO in 2014 by Basti Plimek, really reporting response rate of about 27% in this very small phase 1 study. And there were subsequent phase 2 trial, really reporting about 24% response rate in the first line setting as well. So this was the first randomized phase 3 trial that was reported. The patients were treated, the patients were randomized to receive either pembrolizumab, 200 milligram every 3 weeks for up to 2 years, versus chemotherapy of investigator's choice, including paclitaxel, docetaxel, or vinflunine. This study had two co-primary endpoints, one overall survival, second progression-free survival in total patient population, and the second PD-L1 there's a combined positive score greater than 10%. This is basically expression level in the tumor cells and the immune cells more than 10% range. So this was a positive trial. I would have to say that this is the first randomized phase 3 trial really proving the benefit of the immunotherapy in bladder cancer. So the hazard ratio was 0.73, p-value 0.0022, and the median survival was 10.3 months with the pembrolizumab and 7.4 months in the chemotherapy arm. They also improved 1 year overall survival rates about 13%. The second co-primary endpoint, progression-free survival, was not met. There was no significant difference between the two arms. It's interesting to note that if you look at the median of this, it looks as if pembrolizumab looks worse than the chemotherapy. However, if you look at the tail of the curve, the 12-month progression-free survival appears to be far better with the pembrolizumab than with the chemotherapy. Again, this is really driven by the durable responses that are seen with this class of therapy. This graph shows the confirmed objective response rates with the pembrolizumab versus chemotherapy. Again, this was a significant difference. And if you look at the time to response and duration responses, the time to response was quick in both arms. The response was seen usually in the first staging scans, and there's a stark difference in the duration response between the two arms. In terms of side effects concerned, about 60% of patients has adverse events of any grade with the pembrolizumab arm versus about 90% of AEs of the chemotherapy arm. And this graph shows the common side effects that were noted in both groups. This side effect that were noted with the pembrolizumab, the pruritus, nausea, fatigue, and diarrhea were the four common side effects that were noted with pembrolizumab versus with the chemotherapy. Usually with the fatigue and the myelosuppression with the chemotherapy were noted. Side effects of interest, the thyroiditis and the thyroiditis, pneumonitis, colitis were the three most common immune-related AEs with the pembrolizumab, whereas with the chemotherapy, about 4% of the patients experienced infusion reactions. Really based on this, pembrolizumab does improve overall survival over chemotherapy in patients with advanced urothelial carcinoma following first-line platinum-based chemotherapy. The hazard ratio 0.73, a p-value 0.0022, and this benefit is observed in all PD-L1 populations. Again, as noted, there's no significant difference in PFS between the two arms, and the response rate was significantly higher and also much more durable with pembrolizumab, and much lower incidence of side effects with the pembrolizumab. Actually, there are many other PD-1, PD-L1 pathway inhibitors in urothelial carcinoma. This table sort of summarizes the ongoing trials. Nivolumab, which I did not discuss with you, the study is actually ongoing here in our phase 1 unit. Nivolumab as a monotherapy has shown response rate of about 25% in the phase 1 study. And the subsequent phase 2 trial demonstrated response rate of up to 20% in second-line setting. And avelumab, which is a PD-L1 antibody, this was first reported to have response rate of about 18%, and this is currently being studied in maintenance setting in patients who have a good response after first-line chemotherapy, and they are randomized to receive either avelumab versus best supportive care. And durvalumab, which is a PD-L1 antibody developed by AstraZeneca in its earlier phase 1 study, show response rate of about 30% range. And there are several other combination immunotherapy trials that are ongoing to test this durvalumab with or without tremelimumab, which is an anti-CTLA-4 antibody. Another niche in bladder cancer is that not many of the patients actually are fit enough to receive cisplatin-based chemotherapy. So there are a couple of trials who are cisplatin ineligible. Pembrolizumab and atezolizumab, both of these agents have shown response rate of about 24%. Okay. So again, certainly atezolizumab, it does make a big impact in our treatment landscape for metastatic bladder cancer. However, immunotherapy is active only in small subset of patients, and the resistance to immunotherapy is also often seen as well. As I noted, a significant percent of patients are not fit enough to receive the first-line chemotherapy. And in this era of precision medicine, there's no FDA-approved biomarker-selected targeted therapies for metastatic urothelial carcinoma. To this end, I propose a investigator-initiated trial. So PI3 kinase, AKT, and mTOR pathway has been studied in urothelial carcinoma. This is one of the growth signal pathways. And mTOR has been targeted in a couple of clinical trials in metastatic urothelial carcinoma. These trials really noted some signal with mTOR inhibitor in metastatic urothelial carcinoma. In one of the studies have noted that really impressive exceptional responders with everolimus. So this is a really famous index patient who had an exceptional response to everolimus. This patient actually remained on treatment for nearly 2 years, having a great response. And the investigators actually sequenced this tumor, and they noted that there's a frame-shifting mutation in TSC1. And they sequenced additional patients who had regression to everolimus, and most of these patients actually harbor mutations in TSC1 gene. So TSC1 is a negative regulator of this PI3 kinase, AKT, and mTOR pathway. If you have a loss of function mutations in this gene, it leads to increased growth signals, and thus everolimus may be doing stasis of the tumor growth or regressing tumor. So TSC1 or TSC2 mutations is seen in about 8 to 15% of all metastatic urothelial carcinomas. And my study is designed to look at the activity of MLN128, which is a dual mTORC1 and mTORC2 kinase inhibitor. And by inhibiting both, this may mitigate the feedback activation of AKT, which is known to cause resistance to TORC1 selective inhibitors. And this MLN128 has displayed cellular inhibition of TORC1 and TORC2 pathway with IC50 less than 10 nanomoles, and thus have a potential of greater clinical activity than currently available Repilogs. So what I hypothesize is that tumors that are mutated in TSC1 or TSC2, inhibiting with MLN128 against the mTORC1 and mTORC2 may induce a tumor response. So this is the design of my trial. I am actually selecting patients with this mutation. Actually, the profiling will be done with Dr. Jeff Sklar, who will be sequencing TSC1 and TSC2 genes, and the patient will be treated with this monotherapy until progression. My primary endpoint of the study is the response rate, and I'm looking for about 25 patients in this study. Okay, actually, this study just got opened as of last month. So I'm going to switch my gear to prostate cancer. I'm going to speak to you about the current landscape of prostate cancer and the IIT that I've been working on. So prostate cancer is the most common cancer diagnosed in men in the U.S., and this is the second leading cause of death here in America. And this is the current therapies that we have for metastatic prostate cancer. So really hormone-naive metastatic prostate cancer are treated primarily with hormones with or without the chemotherapy. And it really depends on the burden of the disease. If they have a high burden of disease, these patients are eligible to receive docetaxel chemotherapy for 6 cycles. If it's low burden, then they may just receive combined androgen blockade. Once they develop resistance to these hormonal treatments, it's a really different biology. The disease status we know as metastatic castration-resistant prostate cancer, and the treatments may be targeting this pathway by giving abiraterone, which is a CYP17 kinase inhibitor, which actually inhibits the androgen biosynthesis intratumorally and also in the adrenal gland, and then enzalutamide, which is a more potent androgen receptor antagonist. And both of these agents have been improved survival in placebo-controlled trials. And Sipuleucel-T, which is the first cell-based vaccine approved in treatment of human cancer, this agent did make an impact on the survival by about 2.5 months. And for more symptomatic patients, docetaxel chemotherapy can be used if they are chemotherapy naive, or radium-223, which is a radioisotope that's designed to kill tumor cells in osteoblastic lesions of the prostate metastasis. And the cabazitaxel is a second-generation taxane chemotherapy, which still works even in patients who are treated with docetaxel chemotherapy. All right, again, the problem still is the prostate cancer. Again, there's no biomarkers to use to select which agent to use, and we don't know what sequence or combination regimen that we can use for the maximum benefit for our patients. And the resistance and the toxicities are invariably seen, and with these new therapies, we're actually seeing more aggressive biology of prostate cancers, some anaplastic prostate cancers and small cell prostate cancers. So among the new targets in prostate cancer, PARP has emerged as a valid target for the prostate cancer. The PARP has a multiple cellular function. It's involved in DNA repair pathway and the transcription regulations, chromatin modification, and mitosis, and apoptotic pathways. The function of which is really known in the DNA repair pathway, but it's also important to note that PARP is also involved in the transcription regulation of the androgen receptor. And really depends on the DNA breaks. Our cell uses different DNA repair pathways, and the PARP is involved in base 16 repair. And we know that in patients, in cells that are deficient in HR pathway, the PARP inhibitor has shown to shown to lead to effective cell death. The concept known as synthetic lethality. This is not a new concept. This was first tested in a trial with PARP inhibitor olaparib, published in the New England Journal of Medicine back in 2009, really demonstrating quite impressive responses in patients who had germline BRCA mutations. And there were many trials that have followed after this initial report, and this eventually led to the FDA approval of olaparib in ovarian cancer in patients who had germline BRCA1 or 2 mutations. And the PARP inhibitor olaparib was also tested in patients with a metastatic prostate cancer too. In this small phase 2 study, about 50% study, about 50 patient study, who are actually heavily pretreated with docetaxel chemo and other hormonal treatments, the response rate was seen in about 33% of the cases in these quote-unquote unselected patients. What they did was that they actually acquired biopsies before and after, and they noted about a third of their samples harbor mutations in the DNA repair pathways, including ATM and BRCA2. And about 2/3 of the patients did not have such mutations, and about 14 of these biomarker positive patients responded, and only 2 of the biomarker negative patients responded to olaparib. This is another way to look at the data. This red box indicates this first 16 patients who had a response to olaparib, and 33 patients who did not respond to olaparib. As you can see, there's a significant overlap with these biomarkers defined as mutations in this pathway with the responders. The question is that, it sounds like, DNA repair deficient tumors are responsive to PARP inhibitor. However, the majority of the patients who do not have this mutation, how can we do to improve on what we have? Can we make the, DNA repair proficient tumors to deficient tumors? So hypoxia and the DNA repair genes in prostate cancer has been studied really with Dr. Peter Glaser here and Dr. Ranjit Bindra here at Yale. And actually this is really the basis of my study. Hypoxia has been shown to downregulate DNA repair genes in multiple cell lines, including prostate cancer. So we're using steroid as a inducer of hypoxia. Steroid is a pan-VEGF receptor TKI, which has been studied in multiple tumor types, including breast cancers and also in prostate cancers as well. And we know that in this in vivo study, the steroid can induce tumor hypoxia in this in vivo model. So we know that olaparib works in the significant subset of patients with mCRPC, but mostly in patients with the loss of function mutations in DNA repair pathways. And we think that the combination of steroid and olaparib may work synergistically even in the absence of the mutations in DNA repair pathway by inducing tumor hypoxia, thus downregulating DNA repair genes, and thus sensitizing the tumors to a PARP inhibitor. So this is a design of my study. I'm going to take patients with a progressive mCRPC and be randomizing them to receive either the combination of steroid plus olaparib versus olaparib. And the primary endpoint of the study will be the progression-free survival, and the secondary endpoint including overall survival and response rate. And I'll be acquiring biopsies before and after the treatment. And these biopsy samples will be analyzed for next-gen sequencing, looking at the DNA repair genes, as well as whole exome sequencing and RNA sequencing. This will be done in collaboration with our colleagues at the Broad Institute. And I'll be also looking at the tumor samples for the immune assays, primarily to look at tumor-infiltrating lymphocytes and the expression of immune checkpoint inhibitors. We're working primarily with Dr. Kurt Schopper here at Yale. And here we are testing the hypothesis that the tumors that are deficient in DNA repair pathways maybe have an inflamed immune tumor microenvironment with increased TILs and upregulation of the immune checkpoint molecules. All right, it's a small randomized phase 2 trial. Total sample size will be about 84 patients. And this study is just got activated from CTSU as of last month. So I went quite fast. Just to summarize as what we discussed, I want to review what we know with an immunotherapy in bladder cancer. Certainly, approval of atezolizumab, that represents a huge advancement in treatment of metastatic urothelial carcinoma. There are many trials that are ongoing, looking at different combinations of immune checkpoint inhibitors with other novel targets, either with a chemotherapy or other targeted therapy or other immune modulators. And although we hope for the best, we know that immunotherapy may not cure all bladder cancer patients. I think there's some niche of patients who may derive benefit from targeted therapy approach, which can be tested in a biomarker-driven trial, such as mTOR inhibitor in TSC1 or 2 mutated bladder cancers. And also in prostate cancer as well, with the emergence of these new therapies in prostate cancer, we're seeing more aggressive the prostate cancers, and certainly targeting the PARP inhibitor and the VEGF receptor pathway may be a way to improve our field. With that, I'd like to thank our GU group and our phase 1 group and all the CTO staff and regulatory support staff. This takes a whole village to lead these investigator-initiated trials. Thank you.
We're running a little bit late, so we might have time for 1 or 2 questions. Roy?
Yeah, so, Joe, I was impressed by the bladder